Hi, I'm Dr. Jack Cush from Room Now. I'm here with Dr. Alvin Wells. This past weekend, Alvin gave a fabulous telemedicine, short, unbelievably short, but really helpful talk on telemedicine in a TED format. And this generated a lot of questions about telemedicine, which is very important in this time. So we asked Alvin to come on so I could ask him a few more questions. This piece is meant to be supplementary to his TED Talk, which will be on Room Now for everyone to view. Just check their website and you can watch the video. Alvin, good morning. How are you?
Good morning, Jack. Good to see you.
All right. So let's get into it. Everything's changed with this new pandemic and not seeing patients live in the clinic. So normally I'd be asking you, who's the ideal patient that you'd want to do telemedicine? Right now, it seems like everyone is the ideal patient, but who is the ideal patient? And then tell me how the switch over to seeing only patients remotely has changed your practice.
Yeah, Jack, I usually can imagine this week I've had more phone calls and emails and texts from all of our colleagues trying to see how they can get up and running. We've been doing telemedicine for over 4 years. And I think so some of the things which is exciting this week is that the rules have changed. My group, as others, we've actually have Tuesday of this week, we've closed the clinic. So we only see an emergency patients. I mean, that means I had a guy who came with a gout flare, or somebody who I think had a uveitis flare. Those are ones that were seen physically in the clinic and they're screened before coming in. You asked the question, who is an ideal patient to see for a telemedicine visit? And you're right, I think it's all the patients. Let me take a step back. So before the pandemic, I would say, hey, we could do that to screen new patient referrals. So I have a lot of my colleagues, they'll take the time to go through these notes and say, yes, 10, 20, 15 minutes to review notes and say, I don't want to see the patient. And you're not getting reimbursed for that. So now you can have, let's say, if somebody who's had back pain for 7 years, they have a positive ANA, they want to be seen by you. So don't say no to that patient. You say, hey, let's do a telemedicine visit for 15 minutes and I can screen. You can ask the appropriate questions. And indeed, this might be somebody you don't need to see in the practice. On the other hand, taking about our most stable patients in the practice, the rheumatoid patients, they're coming in, they're doing fine. They just need the okay to keep their methotrexate, to keep their biologic. Those are my quickest and my easiest patients. And then, of course, we have other patients that are more of the challenging ones. Those patients with the osteoarthritis nodules, they want those to go away. The fibromyalgia patient who wants their life to be completely healed. And I think the nice thing about those patients when a telemedicine visit is that it limits their length of discussion. Those patients can go on for 30 or 40 minutes. And on a telemedicine visit, they're forced to actually get it into 15 minutes or for 30 minutes. And actually, Dee, what I tell them, I say, hey, you write down the 2 things you want to talk about before your visit. So when they connect, we have 3 minutes to go through the niceties. I take about 5 minutes to do a virtual exam, and we can talk some about that. 3.5 minutes to do a summary, and then 3.5 minutes to finish up my notes. So in 15 minutes, you can get a good feel for things along those lines. So to answer the question, all patients I think now are candidates, and in some I think it'll be more suitable than others.
So a lot of people are interested in this. How are they going to get up to speed quickly? Of course they could. We talked at the meeting about maybe partnering with another company and whatnot, but that's going to take a few months to get going. What can you advise people now about how to get up to speed on doing either a telemedicine or even a telephone consult with their patients?
So yeah, so first of all, we had a conference call on Wednesday night with Seema Verma, the director of CMS, and talked about now you could definitely do telephone calls. Telephone calls are reimbursed by CMS, meaning Medicare. And then she also said something interesting too, said that now that your practice is the US, that they've waived the requirements for having a state license. So for example, I'm here in Illinois, I can do a telemedicine visit and code for that with Medicare for a patient from California or from Texas. So my practice now is the US. And why is that done? To give an example yesterday, so since we're not seeing patients, our group has got all the doctors together say, hey, can you fill some of these calls? So 1,850 calls in the line for people who had questions about the COVID-19. And again, so there's one young guy I talked to yesterday, 16-year-old with a temperature of 100.3. He hadn't been outside for a week. I asked a couple of questions, talked to his mom. He's had strep throat in the past. I said, this sounds like strep. You need to go to urgent care for a strep swab. On the other hand, I talked to a young lady, a 30-year-old teacher. She's been doing homeschooling for the last week. She had some nasal congestions, a little stuffiness, and a temperature of 99.0. I said, that's nothing to worry about. Call if you get a fever. So you can see, you can stratify those people. Some you can take care of them, alleviate their concerns over the phone. Others you say, hey, you need to go to another facility like that patient with the strep throat. So there's some free platforms that are out there. There's one now everybody's been talked about called Doxy.me, Doxy.me. You can sign up for that today, Jack. You can go on their line. You can do that. They have a platform that the patient can put their information in, and it gives you the kind of a paradigm of what to kind of follow with your patients. That is free. They do have an upgrade for that where you can actually pay a fee. I think it's roughly $30 per month, and that allows you to do more stuff. So take a look at that. You can log on now. And there are other paid platforms out there. I've mentioned in the TED Talk. There's one called Health Tap, HEALTHTAP, and another one called American Well or Amwell. Those you pay a fee to the company, but they give you the whole platform. You don't need to recreate the wheel. Now, what we've done in this with my group as of May of last year, we have Epic now, and we use Zoom as a connection between me and the patient, but everything flows through Epic. So we have a template for a video visit and everything is there. So whether you're doing a paid platform that's already ready to go, you can sign up and get that information. You can get going today. Whether you have a platform with your group using Zoom like we have with Epic, or doing simple telephone calls. There are telephone codes and everything are out there. You can look up those. They are online and available, but I think now it really is open for all of us to be able to help these patients, alleviate the concerns, but also to keep our patients on our diseases and our drugs, keep them stable and making sure there's no issues as we follow them.
So you mentioned that this is all reimbursable now. How do you get your visits to be a level 4 visit, or can you not do that?
Yes, you can, Jack. And so for most of my patients, so I give you an idea. So January of this year, most of the insurance companies like Aetna, Humana, they start reimbursing for telemedicine visits. And that essentially means here that the patient doesn't get a cash payment fee like we do with these other platforms where they have to pay a fee before they're seen. They actually log in with me and I send the bill to the insurance companies. And most of those are level 3 or level 4. So think about this, and this is what many doctors don't do. I'm connecting with you. So one part of my physical exam is a psychiatric exam. You're alert, you're oriented times 3. I mean, you know where you are. You know the president's not Ronald Reagan. So you know all those different things. That's a psychiatric exam. And then I say, hey, open your mouth. Do you have any sores in your mouth looking for stomatitis? I say, and show me your joints. Can you make a fist? We do like the sweets. So do a prayer pose, lifting the shoulders up, all those things that get me to the musculoskeletal. I review labs, and if I prescribe like some Ambien to sleep, or if I give Flexeril for muscle relaxation, that's a level 4. So we document all those different things. I say a template I say, hey, our virtual exam was performed, including physical exam to the oral mucosa, looking at joints and looking at the skin and all those different things. Now, you might have a patient who calls in for an acute visit. Hey, I'm on one of my biologic drugs, and I got a rash where I put that needle in. I need to tell me what that is. Could it be cellulitis? Could it be shingles? Could it be injection site reaction? So the patient puts the camera over the part of the chest, the leg, or where they have the area, and that helps you do. So that can be like a level 2 or level 3 visit. So you see how you can do that, and all based on the depth. But I tell my colleagues, don't forget the psychiatric exam, skin, your joints, and the oral mucosa, and that gets you to a level 3, level 4 right there.
Very good. What do you do about patients who don't have a webcam and don't have access? Can they go somewhere? Can someone help them do it? What do you advise?
So that's the challenging part that we talked about, and I think it's really kind of telling. You know, Obama said, you know, it's easier for a kid in Chicago to get a gun than it is can get a computer. And one of the things we've learned this week with the kids not being at school, that unfortunately, Jack, a lot of the kids don't have internet coverage at home. So Comcast and others now trying to find a way they can provide care for those patients, giving people to give them internet coverage at home. I'm trying to work on a project. Think about this with the local libraries. So now the librarians have nothing to do anymore. So think about a patient could go in and say, I need to go to one of those study cubicles, get me online, and then they can connect with me in a private study room. So we're trying to work with the local libraries on that. So again, as you can know, there's all kind of hiccups and things about that. And this is why I think, you know, the CMS said this week that you can do the telephone visits and you can go from there.
Very good. Do you need to make any adjustments to the front end? I know you're using Epic. Patients can use a portal to communicate. Do you incorporate that into your visit questionnaires or the portal use prior to the visit?
So yeah, so when patients have a portal, as you know, they have access to everything. Now it's something called Open Chart. Everything you record and put into the notes, the patient has access to. And there's a question on that too. Would you be interested in a virtual visit? And so they can sign up and have all that stuff there. And then when I have my schedule in the morning, just putting up how many people, how many injections I'm doing, new patients follow up, and how many virtual visits I have. And we've been doing more new virtual visits now, 15 minutes or 30 minutes to screen them, ask their questions, And then the nice thing, Jack, I can order my labs, I can order my x-rays, and then another week we can get back on the line and say, hey, good news, you don't have lupus. I'm going to send your doctor some recommendations. You can go from there. So again, you see how easy it can be done. And many people, like I said, now they're wasting the time. They go through all these ruckus where you can't bill for your time just to review something. I can do that while I'm on the phone with them. You get to reimburse. And I think that's the reality with, particularly with this pandemic.
So lastly, malpractice would be on everyone's mind. I know that
Yes.
before I was told that in Texas, I could see only people within Texas. Otherwise, I'd need a license outside of Texas. You alluded to this issue at the top of the talk. Tell me how you handled malpractice and what the recent revision might be.
So a couple of things. So with the platform HealthTap, the patient pays $1 and that covers your $3 million, $1 million policy. Okay. And they say you can actually do stuff across the state lines, which is a new for me. And I'm trying to learn out, but as of this Wednesday, like I said, I can see a patient from California for Texas. Does that mean I'm covered by my Illinois and Wisconsin malpractice policy? Or are the other issues off? So I don't know about those because this is a moving target right now. So the other paradigm before now would say, hey, I need to have a license in all those different states and maybe have some coverage in all those different states. So that's a little bit of issue that's up in the air. So for right now with HealthTap, patient pays a fee, you're covered. But right now I tell people still stay within your guidelines of your current practice provider. And then reach out to them. They might have a clause in there, and some are going to have to tweak the clauses because this is a new era now. We talk about telemedicine, and some of those things are not in the standard policies that most insurance carriers have put out there.
So you think CMS is going to allow us to see people across the line for Medicare only patients?
So no, they'll be for Medicare and for Medicaid, of course, but I think what's going to happen, that traditional insurance is going to follow suit. So once CMS kind of sets that standard, that threshold, then other insurance companies say, yeah, we're going to do the same thing. I got 2,000 patients who have a question. Do they need to be screened for COVID? Because you know, to get the swab, you need to have a recommendation from a doctor. They just can't go to one of these drive-throughs and get swabbed. They got to be seen. They got to be filled by a doctor. I have to then order that test. They get a number, and then they go to the doctors to get the swab and everything done. So whether you're talking about COVID-19, somebody who think they might have lupus, somebody who wants to be on a different type of drug or want a second opinion, all of those things are going to change how we're practicing medicine in 2020 and moving forward.
Alvin, this is always amazing. You are a fountain of knowledge on this topic and others. Thank you so much for this time, these questions. I'll encourage everyone to watch your video on Room Now Live and Room Now. Thanks, Alvin.
Right. Thank you very much.